This presentation is designed to make the clinician more comfortable with the use of the Respironics PLV 102 volume ventilator. The PLV 102 can be run off a 12-volt external battery for up to 24 hours. There is a white LED on the lower right side of the vent that is lit up when the vent is being run off the external battery. This vent also has an internal battery that can operate the vent for approximately 1 hour. An amber LED is lit when the internal battery is being accessed. Both the internal battery and the external battery will automatically recharge when the unit is plugged into a wall outlet. The rocker switch will show the capacity left in these batteries, expressed as a percentage, but only if the vent is not plugged into an AC outlet and is therefore utilizing battery power. When the vent is first turned on, it powers up and automatically runs a diagnostic check on itself. If any of the above codes are displayed in the Tidal volume display window, do not use the ventilator. The PLV 102 offers control and assist control modes, as well as both of these with the addition of a Sigh function. It offers tidal volumes from 50 cc's to 3 liters. It also offers an SIMV mode with rates from 2 to 40 breaths per minute. This vent can provide inspiratory flow rates of up to 120 liters per minute. The green LED next to the modes lights up to indicate patient effort. It should be mentioned that if you choose to utilize the Sigh function, that this high pressure limit you will set on the vent will then refer to the Sigh breaths and not the set breaths per minute. Instead, the vent will average the PIP of 10 breaths and then auto-set its own internal high pressure limit, 15 above that average. Sigh volume is not a directly set parameter. Rather, it will be 150% of the set inspiratory tidal volume, and the patient should receive a Sigh breath about every 100 breaths. This vent has a built-in dump valve to release pressures in excess of the high pressure limit. The backup valve releases at 105 centimeters of water pressure. It's interesting to mention that using a heat-moisture exchanger on this vent may trigger inadvertent low-pressure alarms. This vent has the capability of connecting to remote nurse call alarm systems, and it may also be powered by a car charger of the same type that is used to charge cell phones. Many vents have the ability to display the last alarm condition, and so does the PLV. Press and hold the alarm silence button, and it will display the reason the vent last alarmed in the inspiratory flow window. The PLV may be utilized to deliver non-invasive ventilation via a mask. The apnea alarm will only be functional in SIMV mode, and as with many ventilators, keep in mind that if you set your low pressure alarm at more than 10 below the system pressure, it may not be accurate enough to respond to leaks or disconnections. Do not block the rear air entry ports of this ventilator, as it will interfere with its function. Filters cover these air entry ports. Clean the filters, which cover the ports, by running them under tap water and pressing them between towels twice a week. The filters are round, reusable foam. This model of PLV does have the option of delivering high-pressure O2 to the patient via connection in the back. But due to the high cost of running high-pressure O2 through this vent in the home care setting, it is rare to find the vent set up in this way. O2 is usually bled in. If the high-pressure hose is used, however, percentages up to 90% of O2 can be accurately delivered. Internal circuit breakers on this ventilator can be tripped, temporarily disabling its function. Push the button on the front panel to reset the breakers, but if the vent repeatedly trips the breakers, do not use the ventilator. The alarm silence is 30 seconds in duration with an automatic reset. The yellow LED shown here lights when the alarm silence has been initiated. It would be impractical to ask clinicians to memorize all the possible alarm codes. For this reason, a chart is placed on the top panel of the PLV indicating the meaning of the codes. These codes will be displayed in the inspiratory flow window readout. An A1 alarm might display when you plug or unplug the unit, as it has had to switch to its internal battery. A2 is a disconnect alarm. It could be triggered for a low pressure or apnea. A3 is triggered for high pressures. A4 relates to the high pressure O2 source. And A5 might alarm because of a frozen piston or a microprocessor failure. If you see an A5 displayed in the inspiratory flow window, do not use the vent. If your vent must deliver a higher flow than you have dialed in order to meet your other set parameters, it will deliver this higher flow, but the readout in the inspiratory flow window will flash. The vent also has a red LED which lights up if you need to increase your inspiratory flow or in the event your patient is in inverse ratio ventilation. The IDE readout will also blink during inverse ratio ventilation. In SIMV, the IDE window is blank. This vent delivers a sinusoidal flow waveform, so if you want to know the average flow delivered to your patient, you must multiply the inspiratory flow readout by 0.673. If necessary, this volume vent can be converted to a pressure-limited vent with the addition of an external pressure limiter. It is essentially a pop-off to simulate pressure control. The low-pressure alarm has a 15-second delay before the audible alarm is triggered. A green LED lights up to let the clinician know that the 15 seconds have begun. On the subject of sensitivity settings, it is recommended you do not simply trust the knob settings. Rather, watch your pressure dial and record the pressure you visualized that it took to trigger a breath. Remember, the green LED next to the sensitivity knob will flash to show patient effort. If you have set ventilator parameters that the vent is physically unable to deliver, the vent prioritizes them in this order. The tidal volume has the highest priority, and this value will not change. Respiratory rate is second and will be automatically reduced to the number that the ventilator is physically able to deliver. Inspiratory flow rate is the first to change. The vent will manipulate it first to try and deliver your set parameters. Again, it is capable of delivering up to 120 liters per minute of inspiratory flow. The circuit utilized by this vent requires a proximal pressure line to monitor patient pressures, as well as a second pressurized line which activates the exhalation valve on the circuit. The activation of this exhalation valve is how the vent regulates when it will cycle from inhalation to exhalation. This illustration also displays a filter placed at the two patient ports, as well as the addition of oxygen into the circuit or bleed-in O2. PEEP may be generated with the placement of an external adjustable PEEP knob after the exhalation valve. Here we also see the addition of a temperature probe adapter proximal to the patient, as well as a closed suction system. Here is a second temperature probe adapter placed on the wet side of the humidifier to ensure proper functioning of a dual probe humidification system. Here is a closer look at the oxygen bleed-in assembly. Keep in mind that bleed-in O2 is external and not recognized by the ventilator. In this way, the liters per minute of gas you are adding to the circuit will increase the delivered tidal volume. For most of our patients, this flow is only a few liters per minute and will result in a negligible amount of added volume. One technique is to simply turn off the extra flow for a short period of time. Take note of the tidal volume while the bleed-in O2 is turned off versus when it is turned back on. Most patient saturations can tolerate this rapid maneuver. And you can also approximate the added volume by multiplying the liters per minute of bleed-in O2 by 60 to get the liters per second. Once you know the liters per second, multiply that times the inspiratory time in seconds to get how much volume you added. As you can see from the math in this slide, on the liters of flow for most of our patients, the added volume is a relatively small amount. And of course, whenever you are in doubt about the volumes your patient is displaying, you can always add a filter and then a Rice respirometer in line to the circuit at some point after the bleed-in O2. Setting the sensitivity on any vent circuit that utilizes an external PEEP knob can be tricky. Again, the knob is external and the vent doesn't know the pressure is there. It's adding extra pressure in the circuit that will trick the ventilator. So in this example, you want your patient to receive a breath after a -2 centimeters of water pressure pull. So you set the sensitivity at -2. The vent will monitor pressures in the circuit, and when it sees -2, it will deliver a breath. But with the addition of an external PEEP knob set at, say, 5 centimeters, before the vent will allow a breath, the patient would have to pull below the +5 and then down the -2 for a total pull of -7 before they would get a breath. If you have a PEEP knob set at, for example, +5, and you really only want your patient to have to pull a -2 to get their breath, then you would set your sensitivity knob at +3. You'd be surprised when this vent is set up and monitored how often this mistake is made. Remember, when you have external additions, whether it's flow or pressure, the vent doesn't know it's there. Stop, take a moment to think about it. Take into consideration trach leaks, and watch the pressure dial on the front of the vent, taking notice what the actual needle is registering. SIMV is infrequently used on this vent, but if you are asked to set it up in SIMV mode, there's a few things to keep in mind. Again, the apnea alarm is only functional in the SIMV mode. The I to E window will be blank in SIMV. Patient effort breaths that fail to surpass the lower pressure limit alarm will activate a short, undelayed audible alarm, and that's in addition to starting the 15-second countdown to the continuous audible alarm. In SIMV, if you're using the high-pressure O2 connection and you're not also purchasing and using their special O2 sensor, then the patient is only receiving oxygen on the set breaths and not on their spontaneous breaths. And the spontaneous breaths the patient is able to take on SIMV are actually breaths that they themselves pull through the vent, through the circuit, through the air entry ports on the back. These are not pressure-supported breaths, and as you might imagine, there's a considerable work of breathing involved in pulling those breaths. If you wish to make it easier for the patient to access these breaths, or if you have a pediatric patient, you should set up a continuous flow system. In a continuous flow system, you're essentially teeing in a reservoir bag on the dry side of the vent. You need to add the flow on the dry side so that the added flow has a chance to receive humidity. You must utilize a one-way valve so that the PLV doesn't ventilate the bag instead of your patient. And as with most reservoir bags, you want the flow to the bag to be sufficient to keep it inflated. You don't want it to collapse when the patient pulls a breath, but you also don't want flow to the bag to be so high that it pressurizes the bag and shoots flow into the circuit past the one-way valve continuously, whether the patient has tried to pull a breath or not. If you have any other questions, please be aware the entire electronic manual for the PLV 102 has been posted on InfoNexus. It's PDF, so you can save it to your computer and print it later. Take note of what page you are on, because it was meant to be printed and not viewed on a computer screen, so the pages don't always go 1, 2, 3 from left to right. Lately, the home health agencies who are initiating patients on this model vent have also been placing a copy of the operating manual on top of the vent in the patient's room for your reference.